This video is on renal stones. Renal stones are commonly formed in the renal papilla, and this is called nephrolithiasis. There are 5 main types of stones. The most common ones include calcium, whether it be calcium oxalate or calcium phosphate. In addition, uric acid stones are possible, as well as struvite stones that are especially associated with UTIs and cystine from genetic abnormalities. Risk factors revolve around supersaturation of urine within these components. Factors that increase calcium in urine include primary hyperparathyroidism or renal tubular acidosis. Increased oxalate in urine can result from low dietary calcium because oxalate is an anion that binds to calcium in blood. Hence, another consideration is gastrointestinal malabsorption of calcium or oxalate, such as in Crohn's disease. Higher urate levels can be due to gout or leukemia due to destruction of pyrimidines and increased cell turnover, resulting in increased uric acid in blood. Remember, this is from supersaturation of urine, so another cause is just low volume in the urine, such as in the case of renal disease or dehydration. A patient with renal colic will present with very severe pain, and this is due to the stone stretching the ureter and irritating nerves T11 to L2 with inflammation. The presentation may differ slightly due to the exact position of the stone. The 3 most common positions are the pelvic ureteric junction, so the top of the ureter where it joins to the renal pelvis. Also the middle of the ureter, so as it passes over the pelvic brim, and finally the end of the ureter where it goes into the bladder, also called the vesico-ureteric junction. So at the pelvic ureteric junction, the pain may radiate anteriorly and mimic gallstones. Otherwise, it will present with the typical loin to groin pain, and if it's at the pelvic brim, it may also mimic appendicitis. If it's at the vesico-ureteric junction, you'd also expect lower urinary tract symptoms, such as frequency and urgency. Regardless of the position, the patient may experience hematuria and nausea and vomiting. If the patient is febrile, it is concerning because this may mean there is a UTI associated with the stones, and this can really easily progress to urosepsis and hence is a medical emergency and requires surgical treatment. The gold standard for diagnosing renal calculi is a non-contrast helical CT. Bedside investigations include urinalysis and MCS that may show hematuria or signs of infection. Labs include FBCs looking for elevated white cell count, UECs to determine renal function and assess tubular acidosis, CMPs to show calcium and phosphate, which can indicate the type of stone present. Finally, imaging includes renal ultrasound, which may show acoustic shadowing, and abdominal X-rays, which will show calcium stones as they are radiodense. Acute management will focus on analgesia with NSAIDs or opioids. If it is a smaller stone, so under 5 millimeters, the stone may pass naturally with adequate hydration. Larger stones may require intervention, with absolute indications for intervention being impaired renal function and prolonged fever due to the risk of stasis and subsequent sepsis. A stent can be inserted to allow urine to flow past the stone. A stone cannot be removed if the patient is febrile, as it leads to a release of infection and bacteremia. Following a stent, a percutaneous nephrolithotomy can be performed where the stone is physically removed. A less invasive procedure is called an extracorporeal lithotripsy, where shock waves break up the stone. The limitation here is that larger stones may require multiple procedures, as the laser can damage the kidney if it goes on for over an hour. Thank you for watching. If you learned something, please tell a friend who may also find it useful.